All right, Allison.
Okay, good morning. Good morning, everyone. I would like to thank you for joining us today. I'm going to go ahead and call the meeting to order. And Shelley, if you could start with roll call, that would be fantastic.
All right, Allison Welch.
Present.
Ariel Tarango. Bart Dolphus. Present. Good morning. Candace Williams.
Present.
Carrie Lewis.
I'm here.
Thank you. Corey Usher. Dale Woolridge. Dan Matrusky. Mojo. Deborah Kick.
Present.
Dark Gamer.
Present.
Heather Miller.
She's present. She just can't unmute.
Could you have her chime in with her voice, please, when she's back? Josh Peterson would be absent today. Julie Augenstein.
Present.
Laura Smith.
Present.
Maria Salas.
Present.
Michelle Guadnola. Paul Dabrowski. Zane Kelly. Ray Proa. Shanna Clough. Sean Bowker. Or Boker.
Present.
Sorry. Thank you. Stevie Merrill.
Present.
Tiffany Streever.
Present.
Tom Flanagan.
Present.
We have 14. We have quorums.
Fantastic. Thank you so much. Okay, at this time, I'd like to go ahead and do the attendance report or chairman's report first. We'll start with the attendance report, which is, give me just a second. There we go. So just a reminder that if you missed two meetings, the Bureau will contact you, 2 consecutive meetings that the Bureau will contact you to find out if you're still interested in being a part of this group. And should you have any questions, don't hesitate to reach out to Shelley and she can answer any of those for you. We would like to go ahead and welcome Stevie Merrill, who is our newest member. So thank you for joining TEPI. We do have one vacant position available. If anyone knows, if anyone who would be qualified and interested, it's the law enforcement representative with active involvement in EMS, and they can submit their letter of interest and either CV or resume over to Shelley as well. And at this time, we go ahead and like to do a bureau report from Chief Garcia with department updates.
Thank you, Allison. We're just getting the slide teed up. Oh, ready. Good morning, Allison, and good morning, TEPI. Thank you for joining us today. We just have a few slides that we'll run through. I will not cover all of them in detail because we will share out these slide decks with all of our committees this morning. So we'll go through and give some quick department updates. November 13th through the 17th is Crash Responders Safety Week. This year's theme is Protect Those Who Protect You. Up on the slide today, we see that there was actually an event that took place yesterday morning with multiple agencies across the valley, and ADHS extends our appreciation to Arizona's highway incident responders, including fire, EMS, law enforcement, transportation, towing, and so many other responders who risk their lives aiding motorists, clearing roadways every day. In Arizona specifically, we had over 120,000 traffic-related crashes in the last year. And so we really appreciate all those who protect us every day. Moving on, we had another announcement that went out in the last month. Many of you know because you helped work on it, and we want to acknowledge you as the report goes out the door each year. TEPI plays such an important role in our new trauma dashboard and the new trauma report that was published last month. This blog, there actually is a link to the new trauma dashboards. We have both a trauma dashboard that you can filter by year that highlights all of the trauma incidents across the state from our 46 trauma centers. We also have a motor vehicle traffic dashboard that is interesting to check out, and I think it's actually on our agenda today. I won't go in detail through all of our EMS system updates, but we'll continue to share updates on how many providers we have across the state, as well as our appropriation and activities. I want to give a shout out to all of our regions and all of the associations that have participated in our strategic planning most recently. We have been working with the regions on a strategic planning needs assessments to prepare our EMS and trauma plan from 2025 to 2030. We also have been able to provide a small amount of funding to each region for rural paramedic training programs. And again, just a huge shout out to the region. We understand that there are well over 100 paramedics that have participated in those training programs so far with scholarships from the region. So thank you very much. Quickly, I'm going to highlight our EMS and trauma portal and continue to remind folks that it is a resource that we've added additional services to. You'll hear later in the agenda what we have teed up at our new portal is at ems.azdhs.gov. And we can just slide through these really quickly, Shelley. EMS legislative and rule update. I will not go over them in detail, although we'll highlight House Bill 2609 later in the agenda. The thing I do want to stop on is the next slide. Rulemaking updates. You'll hear me repeat this throughout today. We have completed rulemaking that happened in 2022 and 2023, and thank you to all of our stakeholders that participated in those processes. We have pending rulemakings as well. I want to make sure we're sharing that the ground ambulance rulemaking is ongoing. That one has not been scheduled to go in front of GERC yet, so please know that's not on a GERC agenda yet. We've only published the notice of proposed rulemaking, and we have not filed anything further at this point. The next rulemakings we'll have teed up are the EMT or EMCT training and certification, and those are teed up for 2024. Going through the agenda a little further, I apologize for going out of order, but I'll just stop on naloxone leave behind and ask Dr. Bradley if she has anything to add.
Sure. So we have gone live with the naloxone leave behind program as part of our grant, and we're really excited that we have a few agencies that have already received their kits and are distributing this in the community. If you have any questions, this program really allows you to get free naloxone kits given to your citizens. It also has an online training, which is very well put together in conjunction with the University of Arizona, and resource cards that are put in the kits that are specific to your geographic area. We wanted to make sure that any resource card with resources for patients was specific to where that patient was receiving the kit, so that if someone's in Northern Arizona, they're not getting resources in Maricopa County or Southern Arizona. So Maricopa County has 3 resource cards, Central, East, West, and the others are all 30 days. And we appreciate all the input from the University of Arizona who got us some of those more rural resources as well. If you're interested in participating, Adam Rodriguez's email is on the slide deck there, and he can get you information on how to find your agency out.
Good stuff. We won't cover this next slide for today's TEPI presentation. We'll save that for education, but just moving on down the list in the interest of time. Shout out to all of our pre-hospital agencies that participate in AZ Peers. We have 3 slides full of all of the folks that have already transitioned to BEMSTS version 3.5, and I wish I could read all of them, but you guys are awesome. Thank you so much to the agencies that have met those BEMSTS version 3.5 requirements already, and we'll keep following up with additional resources on our agenda today. I am going to jump now to Bureau Report Item B, And I want to make sure we are welcoming our new staff that I don't think everyone on TEPI has had an opportunity to meet yet. And so Erin Henderson, who I think is probably joining us virtually right now, she's our new paralegal project specialist. We also have Karen Barnes that's with us, who has joined the TON team, and we are just thrilled for you all to get to know them as part of the Bureau. To my left is Marielle and also Aubriana, who have joined our services section. And Marielle is our new epidemiologist, and Aubriana is working on our EMS for Children grant. And we're just happy to have you guys here today. I think Josie is joining virtually, so lots of new folks at the Bureau. And we'll have to make sure for anybody here we get you introduced, and looking forward to working with you guys. So thank you so much. I'm not sure who is on the line. Is Carissa going to give the next update on RFP for trauma center, trauma registry? Carissa, are you on the line? Okay, she might not be. Well, I will just really quickly run through items E, F, and G. If we don't have Carissa or Vassal on the line, we are working with state procurement, as we've shared with the committees previously, on a request for proposal for a trauma registry. As you all know, we've been gathering feedback from our trauma centers, all of our registrars and trauma program managers, because we wanted to make sure that we really got the scope correct for this RFP process. When Carissa is able to join, I'm sure you'll hear the process has not officially kicked off, but as it does, we will make sure to continue to provide updates to the committees when we do meet. So no new updates there yet. We talked a little bit about the needs assessment and workforce survey that we've been doing. And again, thank you to the regions for your participation. For the last item, if Vassal is not on, I think that we'll have to pause on that one. Okay. Well, then in that case, can I turn it back to you, Allison, to go through the rest of the agenda items?
Yes, thank you so much, Chief Garcia. We appreciate you going through those. All right, so we're going to go ahead and move on to item number 5 on our agenda, which is our updates. Maria Salas, if you could do a trauma registry user group update, that would be wonderful.
Good morning. From the truck meeting, our next state submission is due January 2nd. They added fentanyl to our substance abuse pick list. And we also went through some neurosurgery procedure codes on our last meeting. And we also went through some of the insurance mapping. And I think, and then we also went through our new changes for NTDB dictionary coming January 1st of 2024. And that's it from our truck meeting.
Great, thank you so much. Heather, would you provide us with the trauma program manager workshop update? Oh, you know what, Heather, your audio is having trouble. Are you able to share that at this time or no?
Might have to move on.
Okay, I was gonna say, I don't see anything. I'm just trying to keep an eye on the chat to see if she was able to say anything in there, but I don't see anything. Okay, so we'll go ahead and move on to Ray Proa and have Ray do our EMS registry user group, our EMSRUG update. Is Ray on?
I think he might be absent today.
Okay, all right. Okay.
It's my understanding, though, I can give a little brief thing because Anne is having me help her set up an EMSRUG meeting after the holiday. Calendar here. And the EMSRUG meeting Monday, the 27th of November, at 10 o'clock.
Monday, the 27th of November. Do we know what, Anne, do you know what time? I saw you did a like, even if you could just type it in the chat.
Yeah, it's going to be from 10 to noon.
Okay.
And I sent out a survey to everybody I had on my list as far as EMSRUG and if they would like some format changes, like a day change in the future,
Yeah.
or maybe only 1 hour instead of 2. And so if you haven't done that survey, I've only gotten about 21 responses, and so that's what I'm going to go by. Please do fill that out so we can do the format that's best for everybody.
Great. Thank you very much, Anne. All right, so moving on to our discussion and action items. At this time, we'd like to discuss and amend and approve the draft minutes from July 20th to our meeting, which is going to be attachment 6A. And can I have a motion to, or can I have a motion to approve those minutes?
I move to approve. Thank you, Barb.
And a second? Oh, sorry.
Second. Okay, thank you, Tiffany.
Thank you very much. And then our next action item is to discuss. Oops, sorry.
Hold
Go
on,
ahead.
we're going to do a vote on that.
Oh, I'm sorry. Yes, you're right. We do need to do a vote. Yes. Can we please do a vote on that? Thank you very much. All in favor, please say aye. Aye.
Aye.
Aye.
Any nays? And any who are withdrawing from the vote at this time? Okay. All right. Thank you very much for that. All right. So moving on to the next one, which is going to be House Bill 2609, with the annual response time reporting requirements that will be effective January 1st of 2024. I'd like to open that up for discussion.
We have background from the. We do. Allison, this is Rachel again, and we have actually some slides. Shelley, if you could put our slide deck back up to slide 22. We wanted to make sure we were sharing some updates with this group on the new House bill requirements that are going into effect as of January. And this would be the forum where if there are questions, we'd love to hear them. And we may not be able to answer all your questions today, but we are planning regional meetings December 4th through the 7th. We're going to go to the central, western, northern, and southeastern region virtually to provide workshops on what to expect and to comply with the new reporting requirement. So if we go through the slides, just to highlight some of the changes that are coming with House Bill 2609 effective January 1, just for awareness, UN initial and amendment application decisions must be issued within 180 days of receiving an application. There is a notification requirement to interested parties when the department does receive an initial or amended application. And response time must be reviewed at least every 6 years based on major population changes since the last census. Those are a few of the changes that this House bill will put into effect come January. On the next slide, some additional changes to be aware of are ADHS will conduct a rulemaking to develop EMR ambulance driver standards for ambulance services that serve rural populations less than 10,000 persons or provide inter-facility transport. The bill does give ADHS exempt rulemaking authority. Next up, a GPS device must be installed on every ambulance to record response time measurement, or an ambulance service must apply for a waiver. And as we mentioned on the agenda, ambulance response time reporting must be submitted in a department approved format and must be made publicly available. Based off of the stakeholder inquiries and requests we've received, our regional sessions that we'll offer at the beginning of December will actually cover the 3 bullet points that you see on the screen here, because those are the questions that we've gotten the most from stakeholders so far. And I have just a few more slides we can share to give you some insight into the exact requirements that are outlined in the bill. The new bill does raise the bar in terms of emergency medical responder program, which must include now emergency vehicle driver training, CPR certification, AED training, training in the use of non-invasive diagnostic devices, including blood glucose monitoring and pulse oximeters, and training on obtaining patients' vital signs, including blood pressure, pulse, and respiratory rate. We have had an ambulance safety work group convene most recently, and the group has provided some additional recommendations. I believe we have some curriculums that we'll go over today in our education committee meeting. And again, House Bill 2609 authorizes exempt rulemaking authority for the department to develop state standards for EMR training and certification in order for them to serve as ambulance attendants in limited circumstances, as the bill says. Next up is the GPS device requirement. This might be the one we've received the most inquiries on so far. The specific language in the bill says, beginning January 1st, install and maintain an electronic global positioning system monitoring device in each vehicle that is used for transport to record on-scene arrival time for response time measurement. And the department shall provide a waiver on a department-approved form to an ambulance service that can reasonably demonstrate it is unable to meet the requirements of this paragraph. We do have teed up when we meet in December with each region step-by-step instructions on if an ambulance service does not meet this requirement, how they may submit a waiver in our EMS portal. And that is our EMS portal is online that many of you know and use on a regular basis. So please come back to us if you have questions on this as we meet in December with each region, and we will be going through the step-by-step instruction. The other requirement that we've gotten inquiries on is response time reporting. I will not pain you by reading this entire thing. I'm going to read the highlighted sections. The new language says the calculation of response time shall begin when the public safety answering point contacts an ambulance service for dispatch and conclude when the ambulance service arrives at the dispatch location. It goes on to say in the highlighted text, the response time data shall be filed in a department approved format, and the department shall make the response time data publicly available. We, again, when we meet in December, are going to go through the department approved form for filing those response times with the department. In the next slide, we just have a few bullets based on some of the questions we get. How will response times be reported? The new requirement says a department approved format, and it will follow a standard template for all CON holders and will be separate from CON renewal application requirements. We have a process that we are teeing up in Image Trend that folks can follow to make it easy and streamlined for everybody that's comfortable with using Image Trend. We also have a backup template that we will present to everybody to be able to look at that process. During CON application renewal, I want to emphasize CON holders will remain responsible for meeting response time currently listed on their certificate. That is not changing January 1st. And at our upcoming meetings, again, we'll go ahead and go through step-by-step instructions on how to access that department approved format and using that standard reporting form. That is the only slides I have for today. And if there are questions, of course, we can take questions on that, since I think the purpose of today was to discuss and find out if there are any questions from the group before we get to our regional meetings.
We have a question in the chat. Sandy, does this include air ambulance response time?
Sandy, it does not. This bill is very specific to ground ambulance and CON holders.
Are there any other questions for Chief Garcia? Or any other discussion items on this? Like crickets this morning. Okay. Chief Garcia, thank you so much for sharing that. And thank you again for setting up those meetings. I'm sure that as we go through that we will have a lot of people who are interested in learning a little bit more about that. So thank you. All right, so moving on to item number C, if we could discuss the technical support and resources for agencies And the AZ peers transitions to NEMSIS 3.5 and those data set requirements that were required by the state as of July 1, 2023. I think, Anne, if you, I'm going to guess that this would probably go to you for any additional background information. But if there's anyone who has any items to discuss in there, please let us know.
This is Anne. I don't have anything really new to add from last time, but all the resources, oh, thank you very much for pulling that up, are on our public facing webpage on the AZ Peers. It currently is still on a 3.5 tab talking about transition. Before the end of the year, I'm going to move this actually over so that it's in with the other data resources and data dictionaries and system resources. But anything you need should be available here. And then also, yeah, the validation rules, I get questions on those, and a way to log in to view them yourself within the system so they're nicely formatted. And a change log. We have had several schematron updates and validation rule updates since we first rolled out our first version about a year ago. So make sure that you have implemented those in your system. If you're not sure, ask your vendor. Thank you.
Thank you. Does anyone have any questions for Anne? Okay. All right. And then the next item would be the the SHARE program, Save Hearts in Arizona Registry and Education Transition and User Group as it's moving back to the university.
Thank you, Allison. This is Gail. I can go ahead and give the update on that. So I know we have been sharing this in the last few meetings, but the Bureau had taken back over the data component from the hospital side of this. So when we look at the shared data set, there were two data sets. The EMS data was streamed directly into AZ Peers. There was no change to that from the EMS agency perspective. The big change is that the Bureau is going to be taking back in-house the data collection from the hospital side. So we are in the process of doing that transition. Part of that data conversion was also the AED list, so that has been completed, I think, this week. That's exciting. Adam is shaking his head yes. So we had several big data sets that we needed to move back over from the University of Arizona. So the first one was the AED registry, and we are in the process of moving over the hospital or CEDAR data registry. So we appreciate all the hospitals that have been patient with us as there's been questions. We do know that there's been quite a bit of questions regarding how do you report certain types of events in terms of when a patient goes to a cath lab, when they go to the ICU, and how that relates to their initial ED admissions. So as those are coming in, we are trying to address those questions. We had hoped to have a user group kind of prepared in the fall to really look and see how can we potentially update the SHARE report moving forward. But the state of transition has been pretty significant for our team. We're not quite ready to have that user group meet. So for those of you who've been on that kind of meeting that we've canceled and rescheduled a couple times, that is the reason why. So we still intend to move forward with that, but we just need to do the data conversion piece internally first. Once we have that component completed, then we really want to bring everyone together and look to see how can we improve this data moving forward. Our ultimate hope is to really try to make this a more automated process. The SHARE program was really groundbreaking when it was developed over 15 years ago, but we know that technology has changed a lot since then, and a lot of the data entry is very manual and time intensive. So our hope is that with some of the data transition, we can try to start automating some of that. So those are the different things that we're looking into right now. Any questions for me from either the hospitals or EMS regarding that transition?
Okay.
No. Any?
All
Thank
right.
you.
Okay, thank you, Gail. It's very much appreciated. Okay, and then the next one is the motor vehicle traffic related trauma dashboard. Thank you, Shelley, for pulling that up.
So I'm going to drive on Shelley vouch here a little bit. So we really wanted this team especially to see some of the data and just not kind of say, hey, we have the dashboard and slides, but to really kind of demonstrate some of the features that are available. I know if you're at on your work or home computer, it might be a little easier to see. Hopefully those of you that work can appreciate this. But there is a link if you go back. But the really amazing thing with this dashboard that Bob from our team have created is that you can query this and adjust it by year. So we have from 2017 through 2022 data. We also have types of motor vehicle crashes. So yes, were they the occupant, motorcycle, pedicycle, pedestrians, and then you can also break this down by region. So you can really adjust it significantly. So if you say, I want to look at 2022, pedicycle, so there's our statewide numbers. And if you say, okay, I want to look at the southeastern region, then it adjusts that. So you have the ability to adjust data pretty significantly based on all those different factors, and you can see how some of these things change. So we've got a breakdown by age and gender that you see in this graph. And then you see here the type of incident, and then we have the ethnicity breakdown, and then obviously the map, because we're gone down to the southern region only, just so it's the southeastern county. If you say, okay, I want to go back to statewide and see how this changes, you can see that there is a change in your distribution on age group. So it's interesting to see how this graph kind of adjusts. You just start adjusting for things like age, and now you see the map at the bottom left where you now have the statewide list as well. So pretty impressive amount of data that is available here in the dashboard. Any questions or any specific areas that we wanted to see? I think when you see a screenshot of this, it's sometimes hard to appreciate how much data is buried in this. And really, once you go to the dashboard and actually start doing different fields, you can see just how much data is available that you can query for your area. Yes.
So the age, go back to the age.
Yeah.
So how has that changed like significantly? Because in my, at least in what we see, is actually Tiffany's here, and we see elderly, ground level fall, ground level fall, ground level fall, ground level fall. So when I look at that, I'm trying to figure out, like hoover back over that. You did it so fast that I was too slow.
So this is specifically for motor. So this is the motor vehicle dashboard.
Right, I understand that. But still, what's the age there?
So right here, so for a statewide perspective, we have here, you see kind of the highest rate,
Right.
in 55 to 54. And then you see kind of the male and female distributions. I had pulled up before the southeast, and you see just kind of this little different dips in your age demographic there. So you see kind of a peak with them younger, in addition to the peak here. That similar age group. And if you
So we're still hovering around 55s,
correct, yes.
more or less.
And then this is the central region. So if you look central region here, not quite as, it's definitely, that is the highest in that age group, but you certainly see the 35 to 44 approaching that as well.
Okay. All right, thanks.
And if we wanted to look at pedestrian, so for pedestrians, this is statewide here. So you can see the statewide numbers. This one is definitely shifted to a younger patient population for pedestrian stuff. Statewide numbers. And you see the breakdown here by county. We'll go through each region, so central region. Northern region, which definitely has that big peak, that younger age group for sure. Southeast also shifted a little bit more younger, but a little older than the northern regions. And then western region is very different work there. So you can see how just that shifts depending on which region you look at.
And we tried to break down like the age of the auto pedestrians and any drug related, like is it a fentanyl crisis, or what's the crisis? Why are these young kids getting hit by a car in the middle of the night?
So that was one of the questions that I asked was, where's our fentanyl data? And then what we realized was that the database doesn't separate out fentanyl separately. So that's one of the things that I'd asked Trug to consider with adding that in specifically, because if we look at most, I think most drug-related instances, unfortunately, these days are fentanyl-related, and we weren't collecting that separately. So that is something that I've asked to have added. So Trug did decide to start including that in the data set. The other kind of tricky thing with fentanyl is that depending on your hospital system, some hospitals, you have to order a fentanyl test separate from your normal drug screen. And so if you don't remember to order both tests, you're going to miss that data, unfortunately, as well. So I do think that is a component. And so that's why I had asked the team to start collecting that data, see if we can
Speak on that, Dr. Bradley. We actually, the opioid test that we had, Raza, fentanyl wouldn't even popped up on it. So actually we were lucky in that our director of lab went to OB, which evidently has a problem with it, and trauma, and said, I need you guys to go to administration and tell them we need to do this. So now for the last, 6 months or so, we actually have been getting the fentanyl test outside of just the opioids as well. So we've been able to track that. So it's definitely doable. It's just getting your administration to go for it.
Good.
I have a question on the line.
Yes, looks like there is a question from Tiffany.
Tiffany, yeah.
I'm Tiffany Schlecht. I'm the trauma program manager at Northwest here in Tucson. I'm wondering, does this take into consideration the age distribution of the respective region's population?
So Vox was in training this week, so I'm going to do my best to answer this as a non-data person. But when I read her description at the top, I do believe that it does take that into account. But it might not. When I look at this, actually it's saying age and gender specific stress rate trauma per 100,000. No, let me correct what I said. It is specific just to your total population. So when you look at the Western region, what we hear a lot from our Western region partners is that they have a very older demographic and quite a bit of a kind of a transient weather-related population that tends to be an older demographic as well, which might be why when you look at pedestrians, this is such a shift to the older age group versus all 3 other regions. So for the
Yeah, I think
Southeast regions where you are, this is definitely a much younger shifted patient population there.
Well, and that's why I'm thinking, because we have University of Arizona down here, it may be shifting the age to a younger age. I don't know how that relates to other regions. But at certain times of the year, certainly our population does substantially increase when school is in session, which may skew our numbers to a lower age range.
It certainly could. And then when you look at the central region here, you see it pushed even younger groups. So definitely quite a bit of data that you can start as you start looking at this and seeing how things kind of adjust and vary on this dashboard. It's, absolutely the fentanyl and the drug exposure, I think is interesting to look to see how can we kind of superimpose some of that data. Hopefully, as we start capturing more of that fentanyl use, we can then potentially really get a better feel of how does that impact our trauma. So great questions to get back about that. Any further questions on this dashboard before we go to the next one?
Can't believe how many tabs there are.
Does this chart capture time of year to reflect the influx of snowbirds?
It's down on this one, though. So this is just annual data only.
Okay.
The next one is our STAB report, and this one we really wanted to make sure we brought back to this team. So STAB did see a preview of this in September. So historically, the Bureau, in conjunction with STAB and TEPI, has put out a kind of PDF annual STAB report, which is required statutorily, approved by STAB and then approved by the director. One of the things that we realized as our team had brought out so many of these different Tableau dashboards is that really we have the ability to make a lot more real-time data. And so we have transitioned the dashboard into this format versus the PDF document. We still do have a summary kind of the year that we will publish each year with this, but we wanted to make sure that this group really saw the Tableau dashboard that she has here. So when we look at the overall trauma dashboard, so there's trauma injuries by year. So we'll go through some of these different tabs here. So we have this, which shows this. Thank you. This shows the number of trauma centers as along with the distribution of level 1s versus level 3 and 4 from 2017 through 2022. The next tabs here is our trauma snapshot, and I'll bring this up here so you can see this is, again, if we want to go to 2022, so these can all be adjusted based on each calendar year. So if you look here, 2022, we have the total number of incidents reported to the trauma registry, the number of trauma centers reporting data, the breakdown from level 1 versus level 3 and 4. We also have documented protective equipment. What percent of motor vehicle crashes, motorcyclists were wearing helmets? Were they wearing a seatbelt or unrestrained? So we have all of that data available here as well. And then we have the breakdown of the top 6 mechanisms of injury. So you can see the breakdown here. And top 6 fatality mechanisms of injury are here as well. And then opportunities for potential injury prevention. So looking at some of these, so 23% of common patients were suspected or confirmed of being under the influence of drugs or alcohol. So to that question that we received previously. So this is kind of a general snapshot here, and we'll go through some more of the tabs. Again, this is available now. We've got 2017 through 2022 data. So we really felt that this is just such an improvement in terms of the ability for people to compare year after year what's happening across the trauma systems. The next tab we go to is our demographic tab. And so this one, we again can query by years. We'll keep it at 2022. We can go to, if we want to say we want to look at level 1 data, or if we want to look at level 3 or 4 data. So if we say we want to look at level 1 data, and then if we want to look at different age groups, so we had a request to separate out the pediatric patient population, so 0 to 17. And also separate 65 and above. So we have 3 options of how you can create the data. You can say, I want to look at pediatric, which is kind of general with 0 to 17. What that does, so you see the data automatically adjusts when you do that. Or if you say, we want to look at the geriatric patient population, and you adjust for 65 and above, and you can see how that changes your graphs and your colors on this on there as well. So the ability to go through here and make all of these adjustments. We have the number of incidents per 100,000 across here. And then we also have trauma intent. So kind of the look through that. And you can see how these numbers changed as soon as I went back to the all age group. So you see here where it was unintentional, still the number 1%, but definitely changed significantly compared to the 65 and older age group. So these are some of the demographic changes query by. Next, we go to the trauma mechanism page. So the trauma mechanism here, again, the opportunity to query by year, by type of facility. So this time, if we go to level 3 and 4, you can see quickly a change in your categories there. And you can also, again, query by your different age groups. So all ages 0 to 17 or greater than 65. So if we want to look at 0 to 17 for this, we see how all of these bars quickly change in terms of your different mechanisms. And then we have the age and gender specific statewide. For some of these, because of the fact that they were very tiny numbers, especially when you get to the pediatric patient population, some of these then just change the statewide data just because of the small numbers. And we have here alongside, so we've got our reimbursement, hospital charges, suspected drug or alcohol use. So again, this is the pediatric population, so this is a much smaller. So this is 3.993%. We say, okay, how did that change if we go to greater than 65 for the age? And we scroll down. We can see, okay, now we're up to 6.4%. So still double pediatrics, but still relatively low. And then if we go to all age groups, what does that do to that? Now we're up to 14.4%. The next tab is for the assault. So we've got, again, the years, the types of assault listed here. And then we've got race specifics, 100,000 residents. And again, you can see some of these are very small groups, especially when we look at the 5 to 9-year-old age groups, so those numbers become pretty small there. And then transportation to the hospital. So this looks at how the patient gets to the trauma centers. So we've got air, ground versus private vehicle. And we can see that data comparison here. And then we also have transportation by injury severity score, attached at the bottom. And then this one looks at air transport by injury location, urban versus rural. And then the final tab on this is just a trauma center map. We had a request to make sure we included this so that everyone, if you has any questions, can look and see where all the trauma centers are by level. So that is a very brief overview of our new trauma dashboard. We are really excited that this is live. I guess this is kind of a culmination of many years of work. And I think this is probably hopefully more useful to the trauma centers, especially if you try to gather data and look to see what is around in terms of your area and for your demographic population. So I really would like feedback from this group as the data expert. Yes.
Well, some of you don't know me, but Alicia Mangrum, I'm one of the trauma surgeons. So a couple of things that were really interesting is when we look at our falls and our hip fractures, are they all going to the level 1 trauma centers now? Are we keeping them more at the level 3, more or less, trauma centers, or have we moved that up to this is the significant injury until they're going to level 1? That's the first question.
Okay, I will go to a different dashboard to answer that question. So then the other dashboard is a fall dashboard.
Okay.
This is the trauma. Let me see if I can find. So while I'm looking for that, the short answer is that when we I've also actually built a table from a request from this group looking at from the hospital discharge database all ground level falls and tip injuries. So she looked at, and a very small percent of those are going to trauma centers versus non-trauma centers across the state. So when we look at our overall ground level falls and tip fractures, a much smaller percent are in our trauma registry. So the only patients that get into the trauma registry and the trauma dashboard are patients that go to a trauma center. So a ground level fall with hip fracture that goes to a community hospital that has surgery there would not be captured in the patient population because they are not going to a trauma center.
Right, and I bring that up, I guess, because there's probably, I'm just going to get over 50% of these patients on some oral anticoagulant, whether it's something as simple as aspirin or Eliquis or whatever. But which brings me to my next question with the children. It seems like you stated that falls were becoming a high injury issue in children. And that's pretty unusual. I mean, I don't mean falls like, playing baseball, playing basketball, whatever, but just falls, ground level falls. And are we facing something that we're not paying attention to?
So this is strictly a fall dashboard right here. And I apologize. I'll have to find out. I know Roxel has it on here. I'm just not finding it real time. We do have a specific report she had put together. So this is looking at fall injuries. This only goes through 2020 right now. And so you can see here for 2020 and the age group. So we've got pediatric filter for that. This kind of breaks down by age. So generally much bigger and the highest kind of rate in the very young pediatric patient population. And then if we go to geriatric, so this is all 65 and older. You see that seat there. And then this is the all age group. So there is that pediatric group with the highest being in that probably 0 to 2-year-old age group that we see there at risk for fall, resulting significant injury that takes them to a trauma center.
Okay. I just think we need to pay close attention to falls and our geriatric. I never thought about pediatrics until just now. One of our trauma providers, and you probably all know Tracy Mahoney, kind of helped bring that to my attention.
And Ann, I know you're on the line. Do you know where the hip fracture report is? I know we have so much data, it's a matter of finding where it's on our website.
I do not know off the top of my head where it is. I think Carissa is on. I don't know if she would know, but I'm not sure where the hip fracture
Okay.
it is. I will take a look though, see if I can find it.
But that was definitely one of the things that we did look at is our overall volume, because we
Right.
do have to remind people that we see a lot of other injuries that go to non-trauma centers and are managed there. And so when we look at just the trauma report, we always like to make sure people remember that we aren't capturing that for some of the show.
Perfect. Thank you. Thank you.
Any other questions or feedback on kind of this newer format?
I have a comment. When you do look at the page you have up right now, in the bottom right corner, you have risk factors and opportunities for injury prevention. In this snapshot, we see in the last couple years, and probably several years, we have seen 1 in 4 patients captured in the trauma registry were suspected or confirmed of being under the influence of drugs or alcohol. So that 1 in 4 has stayed pretty consistent for all the patients across the registry each year. But when we jump over to motor vehicle accidents and we look at the injuries that we have in the trauma registry specific to motor vehicle, the proportion of patients suspected or confirmed of drug or alcohol use, as you know, because you are the providers that see these patients, it's much higher. And so I just want to make that distinction. I think it is important. I think based on the questions we got today, to break down the types of injuries we're seeing and to be able to look at them more specifically to identify those risk factors and opportunities for injury prevention. If we go over to motor vehicle, there's a tab we did not go over. If you want to jump into that, I think it's interesting because there's a fatality tab, seatbelt and helmet use, and then there's risk factors. Here is where you see exactly what the docs are talking about. The drug and alcohol use is much higher for very specific populations.
And unfortunately, we just don't have that fentanyl. And so that's why kind of hopefully we can start capturing that. But really, this group, especially as kind of, we have a lot of representation for drug, is working with your trauma team to say, we really need to be capturing that as part of our screening for patients. So I do feel, we all know that there's a crisis in the country. And if you do a standard urine drug screen, you're not going to identify that unless your system has updated that. So that is really an opportunity to hopefully spread that message amongst your team about how important capturing that data is.
Well, I think it's even more, and I'm sorry I'm speaking so much. I'm going to be quiet. Vicky's pulling at my coat telling me to be quiet. I think it's bigger than we think, because I think what we're seeing, you know, when I first became a trauma surgeon 20 years ago, we fought like crazy about seatbelts, and people shouldn't be ejected out of a car and dying from ejection, and seatbelts, helmet, and all these things. And then where we fell miserably is with drugs and alcohol. Like, we just miserable failures. We just, not only are we failures, I think the people that serve the community are failures, you know, and maybe we should do something like every trauma doctor, every trauma nurse, every trauma, let's take a year off and just say, we're not doing anything. And how do we, because if we don't do something, we're going to always fail in that. We can fix the seatbelt. We can make a child. I can tell my son, you can go ride your bike with your helmet. We can fix those things. But I think we need to, as a state, like, how do we become leaders in something that everybody's afraid to address? So, just a thought.
And then Dr. Gamer, I see you have your hand up, and then I'll go to Dr. Cooper's question next.
Oh, I was just gonna type it into the chat, but you saved me the bother of doing that. Just teeing on to Dr. Mangram's comments, and Eric Cooper chimed in. Is the data saying that hip fractures are going to non-level anything trauma centers to community hospitals? Because aren't a lot of community hospitals level 4 trauma centers, and aren't level 4 trauma centers submitting data? Or is it more nuanced than that? The hip fractures just don't show up in trauma data.
So good clarification. So some community hospitals are level 4, but there's many that are not. So if you are a level 4 community hospital, say in Maricopa County, your data would be in this order set, but your agencies, Garth, had several community hospitals that are not level 4 trauma centers that do get a large volume of ground level falls, hip fractures that get surgical repair. So that patient population is not captured in this.
And at one point, the registry didn't capture hip fractures. They were not inclusive in the data. So, you know, you've got a lot of trauma centers that are submitting, but the hip fractures were excluded.
And many of the, even level 1 trauma centers, an isolated ground level fall hip fracture is not a trauma activation. So it's not, while it may end up in their registry, it's not activated or seen as a trauma patient.
Correct.
And so it's still a different patient population because it's not really coming into your trauma volume because it's not an activation. So there's kind of 3 buckets that you might, the patient population, you might see it at a level 1 without activation, at a level 4 where it is activated, or the community hospital where there's no trauma resources, but there's orthopedic surgery. So the same type of injury may be seen in 3 different types of centers and responses, which to Dr. Cooper's question, you know, one of the challenges is we have the trauma registries. Because of that, we have the patient outcome. We can get a lot more data. A non-trauma center, the only way we capture that data is by the hospital discharge database. And so it's like an IDT post, we really can't tell. It would be comparing like not even apple to orange, or like an apple to a rock. Like we can't compare the data because of the type of data. Yes. That answers the question. An apple to a rock. Because it's not even a fruit at that point. The data that we get is Rachel's going to quote me in that for a while.
We'll pull that soundbite.
Well, great conversation. I think, you know, really with the amount of work that goes into producing this from the trauma center, the data your team collects and puts into the trauma registry, and the work from the Bureau staff in producing this, really, I'd like to take some time to go through this and make sure we don't just say, yep, it's live, take a look at it, so that people can really appreciate kind of everything that flies with this data. Any further questions? I'm giving Shelley back her mouth.
Great. Thank you so much, Dr. Bradley, and thank you so much for the dialogue. And Dr. Mangrum, you brought up some amazing points. So thank you so much. We really appreciate that. So that brings us really to primarily the end of the bulk of our agenda. If anyone has any agenda items to be considered for the next meeting, please send them to Shelley. And then at this time, we'll do a call to the public. And nothing. Okay. There are a number of upcoming conferences which are listed in the agenda. There's, I'm not going to read through all the information, but there's the Tribal Opioid and Substance Abuse Conference, the Southwest Trauma and Acute Care Symposium, the AIMS Fall Forum, and then the NAMES Pediatric Symposium that are coming up in the next, well, some of them actually are currently going on, and then 2, there's one in December and one in March. And then the Bureau also has conference and news on their website as well. Our next meeting will be March 21st, 2024 at 9 o'clock with the location being at DHS and then also virtual. And at this time, we will go ahead and we will adjourn.
Great. Thank you, Allison. Thank you.
Thank you, Shelley, very much.